Hello, everyone. We would like to welcome all of you to this EASL Studio. You already know this is your weekly hepatology broadcast news. Today, we will be discussing in this Journal of Hepatology live episode on the topic, which is the stigma on alcohol-related disorders and also alcohol-related liver disease. My name is Patrizia Burra. I'm a hepatologist working in Padua University Hospital. I'm the chief of the multivisceral transplant unit in my university hospital. And it's really a pleasure for me to launch this studio. This is based on really an amazing review that was published by Professor Schomerus and colleagues. And that was specifically dedicated to the stigma on alcohol-related disorders. And that was followed this year by the publication Journal of Hepatology of a letter by Professor Carrieri, where she underlined what was really the point made by the review. And I think I like very much a sentence that I reported as originally it is. This review is a lucid, profound, and timely analysis of the under-addressed topic. So I think that does summarize exactly what is the problem today. And I will give the podium over to you, Georg, to introduce the first of our speakers.
Yeah, thank you, Patrizia. I'm Georg Schomerus, a professor of psychiatry at Leipzig University in Germany. And I first would like to give an overview about the topic of stigma, because we have researched a lot about it in the field of psychiatry, but I think in the field of hepatology, it's a new approach, which I think is quite fruitful, because it explains a lot of the difficulties we have in dealing with people who have alcohol use disorders. So if we can show the slide that I was allowed to show you, the stigma of alcohol use disorder is centered around blame, and that makes it different from other mental disorders, because people are not blamed for having schizophrenia, for example, but having alcohol use disorder or another substance use disorders is really connected with blaming someone. It's a moral stigma, because it can best be understood as a signal of the environment, of us towards those with a disorder, that we disapprove of their behavior and that we expect them to change. So I don't like that you're drinking too much. You have to stop drinking, otherwise I'll be treating you badly. So, and this being treated badly is kind of maybe the hidden intention is showing people that we disapprove and expecting them to change, but in fact, it doesn't help change. It's isolating people, it's devaluing them, it's making things more difficult. That's the way stigma is doing harm. And it's doing that in three different ways, which are here on this slide. The obvious thing is public stigma, the attitudes of the general public, which I will experience, for example, if I'm drunk and go to an emergency department, and I might be treated differently from somebody who has a heart attack. People might be more unfriendly towards me because they think it's my failure to have gotten drunk. Even if I have a severe alcohol disorder and it's not really that much under my control, still people blame me for being this person with the alcohol problem. So what I'm experiencing is devaluation, being blamed, discrimination, and there are many more instances. And one reaction would be that I try to avoid the stigma, so that I'm not going to the emergency department, or that I'm not telling anybody about my alcohol problem. So even if public stigma is only anticipated and avoided by secrecy and avoidance of help, it still has an effect, because I don't get help and I can't talk to anybody and I won't reach out for help. It's a taboo, which I'm determined to deal with by myself to avoid discrimination by others. So that's the public side of stigma. But there's also an internalized side of stigma inside myself, because I feel ashamed not talking to anybody, because I feel that I'm a failure having an alcohol problem, because I have the same prejudices and the same negative stereotypes about people with alcohol problems like anybody else. And when I realize I'm one of them, I have to apply all these stereotypes to myself, and that is painful. And we know that this leads to loss of self-efficacy. So people are less confident that they can actually quit drinking, which just makes it more difficult to overcome an alcohol problem. But there are also ways to avoid self-stigma. Because if I'm just denying that I have a problem, I don't have to stigmatize myself. If I'm saying, well, I like drinking, that's my way of life. I know other people who drink even more, so it's not a problem that I'm drinking. I'm kind of actively trying to normalize my drinking habit, and by that avoiding self-stigma, which is just a quite understandable way to do, because self-stigma is so painful. So that makes my problem recognition really late. I will only recognize that I have an alcohol problem if it's really, really big. For example, if I have a liver cirrhosis or something like that, which is your field, I guess. But besides of these attitudinal ways of stigma, there's also a structural side of stigma, which is very important, because there are a lot of rules that apply to people with substance use disorders, which discriminate them. I mean, you all know about the abstinence rule before liver transplantation, that is your field, but even if in the field of psychiatry, we have rules that somebody who is actively drinking cannot get psychotherapy. So if I have a post-traumatic stress disorder and I need drinking to cope with my flashbacks, I first need to get rid of my drinking before I get treatment for my flashbacks, which is kind of paradox, because then I have to cure myself before I get help. So there's a lot of rules that really disadvantage people who have one problem too many, which is the substance use problem. And also in healthcare settings, the best way to avoid this kind of stigma is not talking about substance use. If I'm having psychotherapy, I'm not going to tell my psychotherapist that I'm drinking, because otherwise he might just refer me to a substance use service and might stop seeing me as a psychotherapeutic therapist. And also, if I'm not going to the services, I'm just avoiding this kind of problem. So also with structural stigma, the anticipation of this discrimination and of this stigmatization leads to avoidance of help, of non-disclosure of drinking problems, and leads to delay of help seeking or avoidance of specialized services and so on. So we have three ways that stigma is acting: via public stigma, self-stigma, and structural stigma. And it's effective if it's enacted, but it's also effective if it's only anticipated and avoided, because then I'm all on myself and don't get the help that I probably need. So that was my brief introduction to the stigma concept. And now I'm happy to have Patrizia Carrieri here, who wrote this very thoughtful letter on the stigma of alcohol use disorders, particularly with regard to liver disease. She's a researcher for epidemiology and public health in Marseille. And Patrizia, may I ask you, what do you think, which are the consequences of stigma and discrimination in people with alcohol use disorders?
I think it's very important, these questions, because before answering this question, we need to tell more, to say more about how stigma manifests in healthcare setting. And actually, you mentioned some ways it manifests, but there are other ways. For instance, lack of empathy from health staff, or also poor communication between patients and provider. This is a form of stigma. And of course, many people with alcohol use disorders experience something very special, which is called dehumanization. Dehumanization is a condition they are treated as they are not human beings. And this has dramatic consequences, because it may impact mental health outcomes. So you mentioned self-stigma. Self-stigma is really at the heart of the problem of the burden of liver disease, because self-stigma leads to care avoidance. So people tend to avoid to go to services because they are stigmatized, they are discriminated. And of course, people in this case can also experience a progression of their liver disease. And as a consequence, because there is a progression, we have at public health level an increase in the burden of liver disease, alcohol-related liver disease. And there is a kind of vicious cycle between self-stigma, disease progression, and poor social condition, because people who avoid care, they have a more severe liver disease, and they have fewer opportunities to work. So this is why this vicious cycle, which is aggravated by the process of dehumanization. And I think it's important to intervene on these issues, because it's a very complicated issues, and we need several intervention, multi-level intervention to block this vicious cycle.
I completely agree, but I think intervening in stigma is not trivial. I mean, we are used to medical intervention, so we have a patient and we have kind of tools that we can use. But what do you think? What should be the interventions that we use to address the stigma of substance use disorders in order to help our patients?
Thank you. This is an important question, because we know that, for instance, language matters in liver disease. And of course, there is an effort to reduce the language-related stigma. For instance, avoided the term alcoholic in the names, but this is not enough. We need to intervene at healthcare staff level, but also at the patient's level. For health staff, we need to deliver anti-stigma interventions, which are called social contact. Social contact are special anti-stigma intervention led by peers. Peers are people who belong to the communities of people with liver disease or are close to them. And this type of intervention to remove stigma and discriminatory attitudes are very effective. But we also need to intervene on people, because they are suffering from self-stigma and all the consequences of dehumanization. So we need also peer-led interventions, which are based on, for instance, they can be treatment patients education, but with the aim of reducing self-stigma and providing social support, because this is one of the most important interventions we can have against dehumanization. We also have, I think that at the policy level, we need innovative policies, because we need to target unhealthy alcohol use, but also social inequities, because they are so linked together.
I agree. And I particularly like what you said about the peer involvement, because from the field of psychiatry, we know that interventions delivered by people with own lived experience are often much more powerful than those delivered by professionals, and particularly with substance use disorders, where a lot of shame and self-devaluation is involved. If you have someone who has experienced the same, I think you will be much more open for his experiences and his example, really. So I think there's quite a lot of potential in these peer interventions that we are not using yet, probably. Yeah.
And I think, following what you said, Georg, of course there is a link with the stigma and the underreport of the liver disease, the associated liver disease due to alcohol consumption. And that's is really an issue. And this is why the second guest that we have today is Professor Mathurin. Philippe Mathurin is a professor of hepatology. He's the chief of the Department of Hepatology, Gastroenterology, University Hospital of Lille. And he has really run his research group as a head since, I think, more than 20 years. And I think Philippe really has the experience, a personal experience, because he's the one that is the first one in the world that proposed something, an alternative treatment. There was denied for 50 years to some of the patients with really end-stage liver disease. And this is why I would like to call Philippe and to ask him, in the discussion about the stigma, that's a mixture of self-stigma, the public stigma. Is really true? What is the perception that we could realize have a consequence, a delay to the access of treatment for patients with alcohol-related liver disease, Philippe?
Yes, it's a very crucial issue, and I was hearing to my colleagues, and I share most of their expertise. And which is very important is, for example, the terminology alcoholic liver disease, which is completely nonsense terminology, as you know, because it's equal. If you are telling that the terminology that every person have a liver disease related to alcohol is an alcoholic, in fact, it's just an alcohol use disorder. So, as you know, Patricia, the European Association to Liver Disease and American Association to Liver Disease, both of them decide to get rid of this old terminology. So now we are supposed, and I think probably there will be an agreement between the two societies, because the American decide to change this terminology to alcohol-associated liver disease, and for the EASL, the European part, it will be alcohol-related liver disease. So I think it's at least this one is a very important thing. So we need to change the terminology, because if you start to call a patient by a definition which is not applying to himself or to herself, I think we are in the wrong direction. So I think this is an important step forward. The second thing is also to look at this field more, I would say, with a neutral and a position, because research in this field is also associated with a stigma. Because I think when we come to the politician level, it appears that the financial support provided by the countries are clearly not enough. And this is associated, as you know, Patricia, you already raised this point, to the fact that there is a delay in diagnosis and there is a delay in treatment. So every study worldwide, all of them do show that a patient with alcohol-associated liver disease or alcohol-related liver disease had a worse prognosis due to the delay of diagnosis and delay to referral. We need to change this drastically. And we need also to use the same word in every specialty, alcohol at risk, important alcohol consumption, or we can say alcohol above the liver risk, which are associated with development of a disease. So we need to change all those terminologies. That will be helpful. And for example, as you know, for the metabolic part, metabolic liver disease has been called non-alcoholic liver disease. It means that I have a liver disease, I'm just safe because it's non-alcoholic. So we need also to apply to also change this non-alcohol related liver disease that will be more fit, will be better for the field. So this is, yes, I completely share the fact that stigma start with terminology, and stigma start to the fact that the specialty, and I thank all of us for being there. We need also to probably share our experience. We'll discuss about this later on with the integrative approach or screening of liver disease outside the world of liver disease, liver unit.
Do you think, Philippe, that this, let's say, terminology, who is our target? As a hepatologist that we are dedicated to alcohol-related disorders and alcohol-related liver disease, where should we start in order to really to make these changes in the use of terminology?
So first we need to promote this. We need to promote, and EASL and ISL, there's the two scientific society will have a key impact on this. And we need, every time those societies need to explain to the health policy and the government that the new terminology, which is for me better. So yes, I think that at least he has to start with the European society, because they are more powerful than individual initiative. And it has to start from the MDs, the psychiatrists, because even the psychiatric or the specialists in addiction are telling sometimes alcoholic disease. So I think we need to have a common terminology. They have to start by European society, or anyways, scientific society, specialists, and then go to the general practitioner, because if you are able to change the terminology to the general practitioner and the patient, there will be more, I would say, they will have no stigmatization to say, I'm just an alcohol-associated liver disease, but I'm not an alcoholic. You know what I mean? That's very important. Terminology is a crucial thing.
Terminology is definitely crucial. And so following what you said, it is mandatory, let's say, in some way, that in our unit, we cannot really stay as a hepatologist only. Definitely, we know that there is a big change if we have the professionals that are dedicated to the addiction specialists, let's say, either psychologist, psychiatric, and addiction specialists. That makes a big difference in terms of the evaluation of patients. And if we move into transplantation, also the outcomes after transplantation. Surely you have a big experience on that. What is your recommendation for the center that have developed also the liver transplant activity for alcohol-related liver disease?
So for who? It's for George or me?
The integration with.
It's for me. It's for me. Okay.
Addition, yeah.
No, the integrative approach is crucial because, for example, every time a specialist in the liver, without having this interaction with our colleagues, when I start, even 10 years ago, I am telling the patient, you need just to stop to drink. It's abstinence. That's a crucial thing. We just win. There's only one goal, perfect goal. But in fact, as you know, for example, in the field of all the alcohol effect related to the liver disease, the WHO published a risk a level of according to your consumption. And if you decrease by 2 of the risk, you have been associated with an improvement in survival, whatever the cause of death. So as an example now, I'm starting to tell to my patients, it's more than 5 or 6 years ago, it's crazy, but that's the reality, to say, okay, I ask you first to start to decrease your consumption. You have to decrease your consumption by at least 40 or 50%. That is associated with a decreased risk of mortality, and this is important. And this, when you explain this patient clearly what is your objective related to a quantity of a level, amount of alcohol, the patient can follow you. And sometimes I can tell you that with my addiction specialist who is working with us, we are able to explain the patient, and therefore the patient is decreasing his alcohol level. And even at that time, I am telling you, it's a success, not the perfect one, but at least it's a success because you are decreasing your risk of mortality. So this is the integrative approach. And also, I think the integrative approach has to go now to the addiction specialist. We have to be there. We have to identify the patient at risk of having an extensive fibrosis, because if we are able to identify them, we have put this guy on the screening of ultrasound. If we are able to do that, we will improve the outcome because we will decrease the risk of having a late diagnosis of hepatocellular carcinoma. And also, we can also focus on those who are already close to be cirrhotic. So the integrative approach has to go to the double place. So every specialist has to go to outside his world of activity.
Yeah, you reminded me that EASL has really supported the EASL Lancet Commission on the older burden of liver disease in Europe, and really listing some recommendation for the policymakers, and that should really be another point to make with the integration and with the resources to be dedicated to all the units where hepatologists should really work together with psychiatric psychologists and even the social workers, because sometimes there is also the problem of supporting those people if they cannot do on their own. So maybe Gail can take over now for the, let's say, some concept of the final messaging or comment on what Philippe said.
I just wanted to double down on this harm reduction or reduction of the amount of alcohol approach, because I think that's really important. Because if I'm communicating, you need to stop drinking, then it's a yes or no. And if the patient manages to not to drink for 2 weeks and then has a weekend where he or she is drinking again, he feels like a failure, or like having failed this task. And then you have this moral component again, that I know what is right, which is abstinence, and you are a failure because you didn't manage to do that. But if I have a gradual approach, that the less the better, and of course drinking no alcohol is the healthiest thing, but the less you drink, the better, then it's much easier to communicate about drinking, and then you can really appreciate. It's excellent that you're not drinking liquors anymore, but only beer. And if it's only 1 beer in the evening, that's great, because before that it was a bottle of wine, and that's just a lot of more alcohol. So I think it makes the communication easier and lifts this the weight of this moral judgment that you're either abstinent or you are a failure. So I think that's quite important. Yeah, and I think that's a good bridge to the final part of this podcast, the final messages, because Patricia, I wanted to ask you about this communication thing, because we have learned that communication is quite crucial when dealing with drinking problems. How do you think can we improve communication with clients who have alcohol problems?
Yes, I think it's important to understand that the communication is central for people with alcohol use disorder, and the poor communication is a form of stigma. So speaking about alcohol, I know it is very difficult, especially in primary care, Why it is difficult? Because there are several reasons that Philippe mentioned, but one is that people with alcohol use disorder tend to deny their consumption, and physicians really don't know how to talk about this. So one issue, which was also mentioned by Philippe, is that in services, in primary care services, sometimes they are not completely aware about all treatment options and about all possible outcomes. So patients don't feel sometimes ready for alcohol abstinence. And there are other strategies, such as reducing alcohol drinking that you mentioned, reducing alcohol-related harms, but these are not yet expressed, available in primary care. We are not ready yet. So I think really we need adequate training for physicians about how to communicate about alcohol use. And also this is important because it's a way to engage them in care. So training again, it's our message.
Then maybe if I may ask Philippe to give a message, because I think our colleagues that are connected to this studio would like to know what is the outcome when we try to work at top level, let's say in avoiding stigma, including patient access to treatment. So what about the outcomes? How can we evaluate the outcomes to say if we are really getting better and try to solve, at least in our, let's say, centers, the issue overall?
So, for example, we need to change outcome. No, the end point, as you know, the perfect one is survival, and it will be still the best one. So, but we need, for example, to simple things. For liver transplantation, as you know, and Patricia, you are a leader in this field, and I hope we change also what is a relapse in alcohol after liver transplantation. We need to change this because this is associated with outcome. If the transplant person are drinking like us, most at least of us, this is considered as a failure, and we do not do that. None of us are supposed to have an alcohol problem. So we need to change probably also what will be an outcome. Outcome for associated alcoholic liver disease may be the probability of being compensated. If I am coming in the decompensated stages, as mentioned by George, I am decreasing my alcohol intake, and then I am now a compensated person, meaning no compensated liver disease. My risk of mortality is drastically decreased. So we need to raise the outcome associated with the outcome who are validated surrogate marker of death. We need also to differentiate outcome who are in the end of the liver specialist. When the patient is coming with severe liver disease, the job of the specialist is to bring this bridge of living to relapse in alcohol, because the alternative choice, the guy is dying from the liver decomposition. So we need also to bring the fact that there is short outcome related to organ dysfunction, where the pharmaceutical therapeutic company has to come. And then after that, when the guy is being, due to the therapy, in a compensated status, this is an integrative approach with George and his colleagues in order to help us out, at least to decrease the alcohol consumption. If we are there, that would be a perfect world. I want to mention one thing, which for me is very important. Tertiary intervention. Already we are talking of primary, secondary intervention. We never talk about tertiary intervention. Because if you are looking at the field of diabetes, primary, you stop to get weight, you step to get obese, you don't have diabetes. When you have diabetes, you are supposed to secondary intervention to prevent the complication. But when you're already complicated, they are still working on it. It's a tertiary intervention. In the field of alcohol-related liver disease, it's become crazy that we are only talking about primary, secondary intervention, no more tertiary. It means that I already have a cirrhosis, I am on the freeway of death, and nobody cares. We need to change this. We need to say, we have to talk about all the intervention, the guy before having the problem of alcohol use disorder, the guy before having a cirrhosis, but the guy also is at the cirrhotic stage. If we are there, we are in like a very, very far away to what we are now. And I hope that the young has to be there. When change the terminology, the young, you know that, Patricia, when we are the same generation, when we start alcohol, somebody else were asking me, do you have an alcohol problem? That was the initial issue. If you want to work in alcohol, it means that you have an alcohol problem. I don't have an alcohol problem, but I am passionate of patients who are dying and we are not giving them anything. So we need to have those cap. And I think, thank you for for inviting me to participate. But we need to have this interdisciplinary approach of a complex issue, and this is great.
Thank you very much, Philippe. We know that the huge experience that you have. You've been really showing us, as I said, for the first time in the entire world, just to show that we can even propose the daily liver transplantation to patients still drinking. There are different categories. Also, of drinking, different risk factors of relapsing doesn't mean that we had we transplanted patients with hepatitis C for 30 years with 80% of recurrence of the hepatitis C and the need of retransplantation. So where is the comparison? So I think now we have a sort of modern view in transplant medicine too. And as you said, from our generation to today, we really changed it so much. And we believe and we hope that the new generation of hepatologists will really have a different attitude as a medical doctor too. Because to make the change, we need to be convinced ourselves as hepatologists, medical doctors, together with the practitioner. But to ourselves, we really need to trust in what we say and what we do. So to Georg again, over to you, Georg.
Yeah, I'm happy that I can conclude this this podcast with research, because I mean the field of stigma, it's not only attitudes, it's a field of research. We have to show what is useful against stigma, and we also have to show how stigma is doing harm, just to make clear that is a problem. And I'm glad that you, Patricia, have prepared a slide and the last take-home message about the directions of future research. So please.
Yes, thank you. Actually, we know that stigma is responsible from the current burden of liver disease in general, but also in particular for alcohol-related liver disease. So we need to break this vicious cycle, and research can help us to do that, to see how to do that. So there is a relationship with stigma, care avoidance, liver disease progression, and increasing social inequities. So the main message for me is to involve peers in many novel, innovative strategies for fighting against stigma. So, for instance, we have already experienced in the field of hepatitis C that this worked. So we can replicate these models in the field of alcohol use disorders. For instance, we can think about some models involving peers to reduce stigma and helping people to engage in care, for instance. But also we lack of estimates of the effect of stigma and anti-stigma interventions on care avoidance. Because these estimates are very important, because in the future we will need to model which are all these effects, which is the best strategies to reduce the burden of alcohol use disorders related liver disease. And in addition, I think that all you said, Philippe in particular mentioned that we need attractive models of comprehensive care. We know that people with alcohol use disorders suffer from comorbidities, in particular psychiatric comorbidities, and we need to do that, provide care in a simplified with a simplified approach, because they have very complicated pathways sometimes, and this can be done with the help of peers as well. So just to give a final message, let's conduct research and actions with people with alcohol use disorder and not for people. So this is the main message. So we need to involve peers. Thank you.
Thank you, Patricia. I think it's absolutely clear. And with these take-home, let's say, messages, I would like to thank my co-chair, Professor Schomerus, to thank Patricia Carrieri and Philippe Mathurin for the discussion. And I really hope you understand that this is part of the EASL family, EASL community. So may I remind all of you that are not yet EASL member to become EASL members. And as a closing remarks, I would like to thank also the office, EASL office, that's supporting us in this organization, all of you that attended this studio, the Journal of Hepatology staff also, because we really try to publish this paper that raised this issue as we discussed today. And don't forget to join us next week. We will have another episode. It will be dedicated to a very hot topic. which is the palliative care and the management of hospice around in the world. Thank you very much to all of you and see you soon. Bye-bye.